Good afternoon, everybody, and welcome to the asthma training series. This is the first session of 3 for this series. I would like to introduce myself, although my name is on the list a lot. I am Brooke Powell, the program manager for our Asthma Quality Improvement Program. This is part of the Asthma QI program, kind of an extension arm for us to provide training and additional education for those providers and nurses and other healthcare staff that have joined that are not currently part of the Asthma QI program. So want to welcome all of you. A little bit of housekeeping. I will be keeping an eye on the chat. So if you think of any questions that you have for Kellen, I will save those hopefully until the end, and we will answer those. And then there will be information also at the end regarding CME and kind of next steps for that. Slide, please. As always, we want to thank our program partner, the Ohio Department of Health. Slide, please. And I want to introduce today's presenter. Kellen Wheaton is a population health clinical pharmacist at Partners for Kids. In his role, Kellen focuses on improving pediatric patient access to evidence-based medications through provider education and payer advocacy. He received his PharmD and PhD from Ohio State University before starting his role as a pediatric pharmacist at Nationwide Children's Hospital in 2015. In 2019, Kellen started in his current role and has developed an interest in creating and sharing information that can assist healthcare teams in managing medications for pediatric patients with asthma. Kellen, welcome.
Thank you so much, Brooke. Are you hearing me okay?
Looks good.
All right. Always excited. Thank you to the Ohio Department of Health and the Ohio AAP for inviting me to talk today. I do get excited anytime I get to talk about resolving medication access barriers in general, but I'm particularly interested and animated when it comes to the barriers you might experience with asthma medications. I know that you can do all the right things, all hands on deck to try to get that patient the perfect medication in the least amount of time, and it can be very challenging. And that was all before a key medication was discontinued in 2024. So let's get into it. I have a lot of tools and tips to review with you today, and I think that really can help you through this process. And I look forward to any questions, comments, and insights from the people on the call today as we have time at the end. I have no financial relationships to disclose. I've considered the Ohio AAP Diversity, Equity, and Inclusion Standards in preparing this presentation. I invite your feedback in promoting equity within this learning space. If you have suggestions, please email me. So Partners for Kids members are enrolled in managed Medicaid in Ohio. So I want to put this disclaimer out there. Therefore, many of the asthma coverage resources will have that lens and that focus. But don't tune out if you have a high commercial population, because there's going to be a lot of clinical information and a lot of tools that can be applied to pediatric asthma patients in general. So at Partners for Kids as an ACO, we're anchored by really 2 institutions. In our central region, we're anchored by Nationwide Children's Hospital, and in the west region, we're anchored by Dayton Children's Hospital. With that, I want to acknowledge the subject matter experts that we have the privilege to work with as we're developing these tools and resources to make sure they're the most clinically accurate and useful tools for our community providers. So from the pulmonologist side, we have Dr. Lisa Ulrich from Nationwide Children's Hospital, Dr. Dan Evans from Dayton Children's Hospital. We also work with 2 excellent clinical pharmacists, Sonia Sebastian from NCH and Marie Backus from DCH. So we really couldn't do it without this core group that helps us develop these resources. So I did want to give that a shout out. And I'll talk about other team members too, especially our respiratory therapists that help us with some of these tools and resources as well. So the main thing that I hope you can take away from this talk today is how to describe and think through some of the barriers that you might experience with asthma medications. With that, we're going to use a patient case and walk through clinical and coverage resources to prescribe guideline recommended medications and avoid insurance barriers that can cause headaches and delays. single maintenance and reliever therapy, I know it's been around a little while, but I know there's still some barriers in terms of getting access to this that you're facing in the community. I don't have a silver bullet, so to speak, on this one. There is some things to think through, and we'll talk about those that can help you get access to two combination inhalers per 30 days to be able to use this particular approach. And then we're going to take a little bit of a pivot into describing some best practices for improving asthma medication ratio. So asthma medication ratio is something we're focusing on right now as a population health measure. And I'm going to talk about why I think you're going to see it in the coming months and years and have opportunities to collaborate with a number of institutions and partners. So when I think about common medication coverage barriers, there's really 4 topics I'm going to kind of be the theme of today. The situation where prior authorization is required. I know nobody likes to see this message come through. It definitely causes barriers and requires a lot of time to get through those prior authorizations. And so we'll have a segment where we're going to talk about, is a prior authorization really needed or not? So asking that question and what times you should be asking that question. And of course, we have a number of formulary changes as well you have to deal with. As things have shifted and have new medications become preferred medications go non-preferred, this causes challenges. And I think it's really caused a lot of challenges in 2024 with the discontinuation of brand name fluticasone propionate, HFA. And that leads us into formularies misaligned with guidelines. So nothing's more frustrating when you want to prescribe the right medication that's going to get the best outcomes, and it's just not preferred on formulary. And so we'll talk about some avenues to communicate effectively with the pharmacy and with payers to try to resolve those barriers. And then ultimately, you might have knowledge gaps at the pharmacy that through this all, after navigating all of these things, there's still going to be things that could occur at the pharmacy to prevent the patient getting the medication in a timely manner. But we're all learning together. The community pharmacist is learning new guidelines. They're also trying to keep up with these formulary changes. So I'll give you some tips and tricks to kind of talk with the community pharmacy in a way that can create a great relationship for you and the pharmacy to get patients their asthma medications. So today we're going to work through this particular patient case. It's a fairly straightforward case on the surface, but we'll find when you go to prescribe medications, there'll be some barriers. So we have an 8-year-old patient that's Ohio Medicaid insured with mild persistent asthma starting on a controller medication. So when I present prescribing resources today, every slide is going to look like this whenever I introduce a new resource. So you'll have all these resources are freely available on the Partners for Kids website. If you were to look in your search bar in Google or search Partners for Kids and then search resources, they should be one of the first things that comes up in terms of where to find these resources. That's a quick way to do that. And then there's also a search bar that you can search keywords like asthma or diagnosis to get to some of these specific resources. These QR codes can be helpful during this presentation if you want to see what this resource looks like on your phone and follow along. So our first pathway is really all-encompassing. It's an asthma outpatient management pathway designed to really cover a number of basics and fundamentals from diagnosis, treatment, and education and follow-up. And we're going to walk through the patient case with this pathway so you get comfortable using it. So the reason we're going to break this down is because it can look pretty intimidating initially if you've never seen this particular tool before. So let's get into this patient case where you have that 8-year-old that shows up to your office with symptoms consistent with asthma. The top left corner of the pathway, you're going to see concern for a new diagnosis of asthma. And the first thing you may want to do is classify asthma severity once you've determined the symptoms are consistent with asthma. And by classifying asthma severity and clicking that link, it's going to take you to a table that we've modified from the NHLBI. So this is a very interactive pathway. There's many different tables and resources built within it. And you can get to all of these from the front page of the resource that I showed initially from links, or you can follow down through the pathway and get to them that way as well. So it really meets you where you're at. If you just want to go to a medication table or a table like this, you can get there pretty quickly. So you've reviewed your patient, you've assessed some subjective and maybe some objective lung function information, and you've determined that your patient is mild persistent. On every page, there's an opportunity to return to the pathway, and that's linked here. So that makes it a little easier to navigate. You're not scrolling. You can click this link, and it'll take you right back to the front page of the pathway. So we're going to live in this treatment area quite a lot as they were focused on medications today. And so this also is modified from the STEP therapy tool from the 2020 NHLBI asthma-focused updates. And we're just showing the preferred medication options here. There are alternative treatment approaches that you can go to the link here at the bottom of this page. We link you directly to the 2020 updates to see the full scope of medications. But this gets you really a lot of opportunities for treatment right here in this table. And so if you find your patient's age on the left-hand side and move from left to right, you'll end up at step 2, or mild persistent. Each of these boxes is clickable. So if you click on it, it will take you to a medication table that will give you some guidance for what to use. So I know this can look a little busy, but this is inhaled corticosteroids table. It's low and medium doses are represented here. So those are low and medium starting doses. It's broken down by inhaler mechanism. So you have metered dose inhalers. Those are essential to be able to use with a mask or a mask and spacer. So spacer compatible medications. We have dry powdered inhalers, and we have nebulized solution there as well. So this particular table has layered with what's covered for our Ohio Medicaid patients by bolding those medications. So in this case, when you look at an 8-year-old, you're probably going to be drawn to those metered dose inhalers that can be used with a spacer. So when we do that, we see we have 2 options. We have fluticasone propionate HFA and mometasone furoate HFA. So only 2 options in this space. Flovent's bolded and covered. So we're going to go with that particular product because it doesn't require prior authorization, and find our patient's age, and a pretty standard approach, 44 micrograms, 2 puffs twice a day to get this patient started. So that's just a recommended starting dose for that medication that would be covered for the 8-year-old, covered by a Medicaid plan. I did just want to mention, we're going to dig into this a little more later, but we have greater than equal to 12 for these dry powdered inhalers. That is not the FDA approved dosing indication. That's just an opportunity to stop and think about some of those younger patients, whether they're ready to use a dry powdered inhaler, and if they have the lung strength to breathe in the full dose from those medications. So that's a case-by-case basis, but I just did want to call that caveat out there. You could use these for younger patients. All right, so you've gotten this far, you've used the pathway, or you already knew this because you've treated a number of patients with mild persistent asthma, and you prescribe Flovent, fluticasone propionate HFA 44 micrograms with a spacer. But of course, the patient reports pharmacy does not have in stock. So now you're maybe wondering what to do next, to how to get this patient a medication. And that really brings us to our second resource. I'm going to back that off for 1 second. This resource is a spacer-compatible ICS, inhaled corticosteroid guidance. This evolved from hearing from our community providers that were challenged with what to do next. Through this challenging time in 2024, where brand name Flovent was discontinued, and it was a little scarce in the community. I don't know how it seems to have been gotten better, but during this time it was a little scarce. So I want to walk through that particular example for a Medicaid patient. And then we'll also see what happens when you have a commercial patient that might not have a metered dose inhaler covered. What do you do in those circumstances? So we created this tool that will kind of walk through this particular patient with and provide some guidance along the way. So I realize this can be a little noisy, so I'm going to try to give us a starting point here. So we're starting right up here where you have a patient. The first question I'd ask is the patient insured by an Ohio Medicaid plan? If yes, because Ohio Medicaid made a fantastic decision to move the authorized generic product that's available in the marketplace to preferred, so their patients have an uninterrupted access to this medication. So that's the first question. If it is, go ahead and prescribe that medication, and that would be your first line approach for this particular patient. But it's not in stock at the pharmacy, so we're down here. The first question I have, there can be some miscues happening between the patient and the pharmacy. Is it not in stock, or can they not order it at all? So that's the question I asked: is can the pharmacy order the inhaler from their wholesaler being where they get their medications from? If yes, ask that pharmacy to order it in. It may take a day or two for that to get in, but it would be probably the quickest way for that patient to get access to that medication that you really want. If no, my next question would be, are there other strengths available? So right here. If yes, you could consider, so say the 110 microgram fluticasone propionate is available. You could consider using the 110 microgram strength 1 puff BID, which would get you very close to that 2 puffs of the 44 micrograms BID. So during this time, anytime there's shortages, there are some things to think about to be creative to get your patient a roughly equivalent dose of the inhaled steroid. But if not, the other option here, if there's not another strength available, would be to check with another pharmacy, because as I mentioned, there's wholesalers for each pharmacy, and those wholesalers can be different pharmacy by pharmacy. So just because one pharmacy doesn't have it doesn't mean another one won't. So you still might have some options there. So that's our Ohio Medicaid patient. Well, let's take a patient that has a commercial insurance. So you've checked the formulary, or you've been notified that fluticasone propionate HFA is not covered. The only other option that we mentioned is Asthma Next HFA. So the question is that preferred? If yes, you follow that same particular pathway and might have to remove some barriers from access points at the pharmacy. There's also a steroid equivalency table that we'll talk about and review to help make that transition between fluticasone to mometasone. But if it's not preferred, you're really left to decide, do I put that patient on a dry powdered inhaler? Are they old enough? Are they mature enough? Can they get that medication out of the inhaler or not? Or do I need to submit a prior authorization? So what I have here is some sample prior authorization language in the bottom here, which can really help you be very descriptive in your approach when you're communicating with payers. You don't have to be this verbose. This is a great template, but you can just mention that the patient doesn't have the lung strength to breathe in this medication properly from a breath-actuated inhaler. And that is following guideline-based approaches to use an inhaler that can be used with a spacer for a patient of this age. I put some references that talk about lung strength and where that cutoff is, as well as some GINA guidelines in the EPR3, where it does talk in detail about needing a spacer for these patients. If I'm a clinical pharmacist reviewing this, I would be stunned if you found a denial from something like this. And if it's happening, that's really a shame. There may be some miscommunication going on there as well. But if you're being this descriptive, you have a good chance of getting a prior authorization approved. And I'll mention, I know organizations like the AAP and others around are doing good advocacies with payers to make sure to try to convince payers to put these as preferred for young patients. But some of the greatest form of advocacy is submitting the prior authorization, because payers are going to continue to keep tabs on how many prior authorizations they're getting for specific medications. And if they're getting a ton of prior authorizations for these products, they're going to take a hard look and decide, do we want to do all that administrative barrier for these patients? Is it clinically appropriate for us to do that? And so as providers or as healthcare members of the healthcare team, submitting the PA might be the best bet to get these covered ultimately. Okay, so I gotta undo this pen here. All right, so getting back to what we talked about, being agile with that particular strength of fluticasone propionate and going with a 110, 1 puff twice a day would be a fair way to navigate out of a shortage indication where they have that strength available. We talked about this a little bit already, but if you do need to switch from fluticasone to mometasone, the question is what's the dose of mometasone that's estimated to be equivalent or roughly equivalent to that dose of fluticasone? And so that's why we generated this next resource, which is an asthma inhaled corticosteroid table. I'm going to zoom in on this a little bit on the next slide to kind of help us walk through this. But I know that there was a lot of transitions and challenges with transitions during this time. So this should help guide you through some of those processes. So what we have is each inhaler. So we have inhaled corticosteroids, but also combination medications in this table. So if you want to switch between these, you can also find those rough equivalencies as well. But we have the delivery method, so it can help you identify inhalers that are breath actuated versus spacer compatible. The strengths available in the marketplace to help you get to the dose you need. And then the typical dose frequency. We're going to talk about a new medication that's preferred for Ohio Medicaid patients that you might not have as much experience with. So using this table to determine how to dose those newer medications would be a good reason to use this. And then we have the low daily dose, medium daily dose, and high daily dose for children and teens and adults. So we've broken it out like that. So for this particular example, you found that fluticasone dose to be anywhere between, you're at actually 176 for a total daily dose for this patient. So you're at the low daily dose. And if we find mometasone, we'll find that the 100 micrograms daily is roughly equivalent to that same dose. And if we see what's available for strengths, you have a 50 microgram inhaler available. So if we come back to the question and you use that tool, you'd identify the option, one of the options for a new therapy is mometasone, HFA, 50 micrograms, 1 puff twice a day with the spacer. So because this was such an important event that occurred in 2024, the discontinuation of fluticasone propionate brand name inhalers, I did want to just review why that occurred as a little bit of a foreshadowing for what could happen in the future, and just to make you aware to keep up to date on some of these things. So the important thing here is that for manufacturers to have their medications on Medicaid formularies, they have to enter into the Medicaid drug rebate program. In exchange, the manufacturer provides a discount to Medicaid for their medications, and these are known as rebates. So it's really designed to make medications more affordable to Medicaid programs and to try to offset inflationary drug price increases. So it's overall a very good thing. Prior to 2024, there was a maximum amount of rebates manufacturers would pay. And there was important legislation that went into effect on January 1st, 2024 that removed this cap. And what happened here is this caused some manufacturers to pay more in drug rebates to the point where they're paying more than the actual cost of their medications that they're selling it for. In that case, some manufacturers chose to remove their products from the marketplace. And an unintended consequence of that is that we had issues with access to these medications, not only for Medicaid plans, but also for commercial plans, because these are no longer available in the marketplace. There is about 15 to 20% of medications overall that we estimate to be at the current rebate cap. So this impact could hit multiple brand name medications. Because many brand name medications are preferred over generics because of the rebate structure on Medicaid plans, this can cause some definitely disruptions on formularies and also impacting the commercial space in terms of accessing medications. So all this to say is we'll keep an eye on this. We're very closely watching these things. And if you keep an eye on the Partners for Kids website, anytime you have issues with some of these medications or are wondering if these things are happening or there's a discontinuation, we'll hopefully have something on our website that can help you through those times. At this point, I want to transition and we're going to step a patient up, and it's going to give us an opportunity to talk about some insurance barriers to single maintenance and reliever therapy, which I really love the concept. I really like the study results, but I know the struggle is real when it comes to access barriers. So we're going to give some areas of opportunity to maybe overcome those barriers and give you a little more confidence when deciding to approach SMART with your patients. So you got that same patient with persistent asthma, and you determined they needed step-up therapy. So if we go back to the pathway, there's a section in the middle of the diagnosis table where you're having a routine follow-up visit and you're classifying asthma control. So if you select that particular link, it will take you to another modified table that's consolidated from the NHLBI, which gives you an indication of which symptoms to review, and if they're either well controlled, not well controlled, or very poorly controlled. So after reviewing symptoms and maybe some objective lung function results, you determine that they're not well controlled. Before stepping up, it's always a good idea to review adherence to the medication and make sure there's no access barriers and assess that they're using the inhaler correctly. If all those things are true and you're in agreement that this patient's not controlled, it's time to take a step up. So if we go back to the treatment table, you're going from step 2 to step 3 with this patient. So now you're using a daily and as needed low dose combination inhaler with an inhaled corticosteroid and a long-acting beta agonist for Motorol. So we're going to review this approach just to make sure everyone's level set on what SMART is. Like I mentioned, it's an inhaled corticosteroid and a long-acting beta agonist combination medication known as ICS-LABA. It's for moderate persistent asthma patients 4 and older who are uncontrolled. This ICS-LABA can be used daily and as needed. So that as needed use would take the place of a short-acting beta agonist like albuterol. The long-acting beta agonist, the mnemonic I use to remember this is formoterol is fast-acting. So that needs to be the long-acting beta agonist in your combination med. So if you don't want to remember that, that's okay. If you're keeping this pathway handy, we go over SMART in one of our tables here. So that link takes you to what options you have to use in the SMART approach. Fortunately, they're both metered dose inhalers, so they can be used with a spacer. You have budesonide formoterol, otherwise known as Symbicort, and mometasone formoterol, otherwise known as Dulera. Symbicort's bolded because it's the one that was studied the most. Budesonide formoterol is definitely has the most data on it. And also you can use, Ohio Medicaid enables you to do 2 inhalers in a 30-day time period, which is really what you're going to need if this patient's going to be using it daily and as needed. So there's really not much different between the age groups. The low dose inhaler strength for budesonide formoterol would be 80 per 4.5. It would be 1 to 2 puffs twice a day and 1 puff as needed, a maximum daily puffs of 8. Different from the 12 and older, which the max is 12. We did go into more detail down here into this table to kind of guide what a prescription would look like. If you haven't had experience writing this, it's a little bit different. So to be very descriptive in this prescription is going to help you resolve some access barriers. So inhale 2 puffs twice a day. May also inhale 1 puff as needed for symptoms, max 8 puffs per day. Dispense 2 inhalers for a 30-day supply. And that is going to alert the pharmacy and the pharmacist that you're trying to get those 2 for 30. You don't want 1 for 15. You don't want 2 for 60. This is a very specific number of inhalers for a specific day supply and should indicate to them that you're using it with a new approach. So like I mentioned, with Ohio Medicaid, you'd be able to get two inhalers for a 30-day supply. We'll talk a little bit about what could happen with commercial payers in a second. I did put a reference down here in the bottom left corner. It's called A Practical Guide to Implementing SMART in Asthma Management. I think it gives a lot of good frequently asked questions answered and kind of gives you some deeper insights into what decisions to make when for this approach. All right, so you prescribed brand name Symbicort, 80 per 4.5 with a spacer to be used daily and as needed for this Medicaid patient. Of course, we're going to have some disruption here. Pharmacy sends communication that a prior authorization is needed. So this brings us to, does it really need a prior authorization? And asthma medications lend themselves well to this question because there's a lot of brand name preferred over generic medications in the asthma space. So it's always a good idea whenever you think something should definitely be covered to kind of check that out. And I'm going to show you a good resource to check out. This is the Unified Preferred Drug List for Ohio Medicaid plans that Partners for Kids maintains. And we take that large Medicaid list and really boil it down to the most commonly prescribed medications for primary care pediatrics. So we, of course, one of the most common conditions is asthma. So we have an asthma section in this resource. You have an inhaled corticosteroid section, so just those ICS alone. And then we have the combination medication section as well. I'm going to detour on the inhaled corticosteroid section because there are some updates I want you to be aware of that were effective 4/1/2024. So this table is laid out with the medication, the strengths available, the average cost per script, just a benchmark price, And then if there's a check mark, it's preferred, no PA required. There might be some subnotes here about age restrictions that can be helpful. And what I wanted to mention on this slide is that effective April 1st, you have 3 more dry or breath actuated controller medications that are preferred for your Ohio Medicaid patients. You have QVAR ReadyHaler, which is beclomethasone. You have Pulmicort FlexHaler, which is budesonide. And then you have Arnuity or fluticasone furoate, which is Arnuity Ellipta. So you have those 3 options now. Each are a little bit different. Using that inhaled corticosteroid conversion table can give you a little more details about these medications. There may be some advantages to one or the other. They do have some of them have different frequencies, which can be helpful for adherence and things like that. So I did want to make sure you're aware of those opportunities now for your patients that are a little older that can use a breath actuated inhaler. But we're talking about Symbicort. So here's the combination medications on this tool. And if we look at Symbicort, there's an important subnote that brand is preferred. If the pharmacy by default runs generic medications. So if there's a generic and a brand available in the marketplace, the pharmacy 9 times is typically the generics preferred. So they're going to run that through by default. When that happens, if they don't change it to brand on their own, they're going to send you a prior authorization request. This isn't a PA needed. This is a call to the pharmacy asking them to run it through for the brand name. And they have a code on their end that they can get through this rejection without having to submit that prior authorization. And you'll see that there's a lot of other medications on this list that also have those same notations. So when you run up against that PA required for something you're feeling really comfortable with for your Medicaid population, keep this in mind. So we went over the first barrier here for Ohio Medicaid. Make sure the pharmacy is processing for brand name product. They have a dispense as written 9 that the pharmacy uses. You don't have to say that. It's not like a DAW1. This is something they can use, which tells the payer that the insurance prefers brand. The other thing that the pharmacist may need to do is place a high dose override to approve those 2 inhalers per 30 days. I've worked with pharmacies to try to do this, and it's very straightforward. They just might not catch that it's asking for a high dose override. They might think that it's high dose PA needed. So just one additional barrier among everything else to try to get this through. But the pharmacies are really amenable to this, and letting them know that you do want 2 per 30 days will allow them to push through that override. So this is a good process to keep in mind for those smart prescriptions. Commercial insurance is tougher for me to tell what's going to be covered. Can you get 2 per 30 days or not? So I provided some prior authorization documentation if you're going to use SMART. So just again, the theme here is be precise in the language to let them know you want 2 per 30 days to use twice a day as a controller and a reliever. Twice a day as a controller and as needed as a reliever. And that the approach aligns with the national asthma guidelines to reduce exacerbations. So hopefully that will be helpful for when you're submitting these prescriptions and trying these out with your patients, because I think there's a lot of benefit to a patient using not only a beta agonist when they're needing relief, but also a steroid when they're needing relief. So I like this, a longer acting beta agonist and a steroid to help actually treat the airway. All right, so we made it through our patient case here where we started them out on a low dose inhaled corticosteroid. Your knee jerk may have been to step them up to a medium dose inhaled corticosteroid, but in fact, the guidelines are suggesting an inhaled corticosteroid and long-acting beta agonist combination inhaler. Even if you don't use SMART, still stepping up to that ICS LABA is going to be more effective than increasing the dose of the ICS alone. So keep that in mind. So you finally got that through in the insurance and you did your due diligence. We're done with patient cases as it pertains to the pathway, but I did want to come back to the last section of our pathway, which is where you'll find follow-up and referrals. So really straightforward information here. Just some suggestions for how frequently to try to get your patients to follow up based on their asthma severity, and also whether they're poorly controlled or not poorly controlled, how frequently to potentially follow up. We also have some patient education tools we link to, and I'll review a couple of these at the very end of this presentation, so you know there's a couple more free resources available that you could use. So now we're going to transition into asthma medication ratio, like I mentioned earlier on the presentation. May feel like an abrupt pivot, but I am going to try to focus on this measure, and I think you might be hearing a lot more about it in the coming months. So hopefully what we've talked about today will give you some guidance for how to improve asthma medication ratio. So as a population health pharmacist, AMR is really top of mind because it's the focus of a group called OAK. It's called Outcomes Acceleration for Kids. This is a very new collaborative that I hope each of you will have a direct or indirect relationship for years to come. It's comprised of Ohio Pediatric Accountable Care Organizations, Ohio Partners for Kids, Ohio Children's Hospitals, Medicaid Managed Care Organizations, and it's all anchored by Ohio Department of Medicaid. So a really exciting group that's focused on 4 areas of quality measures: well care, behavioral health, sickle cell disease, and germane to today's topic, asthma medication ratio. If you look at the map, that's why I think if you're anywhere in Ohio, there should be some opportunity to work with these partners to try to improve asthma medication ratios. Keep that in mind as you might hear about these from these particular groups. All right, so let's do an overview of asthma medication ratio. Like I said, I know it's not new, but I think I needed a refresher when it came back to the forefront. So I wanted to give this group a refresher as well. So AMR equation is controller medications over controller plus reliever medications. So you've got your everyday medications and your relief medications for symptoms. The key is to have a ratio greater than 0.5. So a simple way to think about this is your patient's filling more controller inhalers than reliever inhalers, and that would inherently put their AMR greater than 0.5. So if we just reinforce this with a particular example, this patient's filled 3 fluticasone propionate controller inhalers and 6 albuterol reliever inhalers. So 3 divided by 9 gives us a 0.33 AMR, which would indicate they're non-compliant. So they would fall out of compliance with this particular measure. And this is 12 months of information. So as you can see, it's more than just a number. You can identify that there's areas of opportunity to improve adherence to that controller inhaler and really ask some tough questions about, are you using albuterol for relief? Are you getting relief when using it? And really assessing how that is being used to the point where they're needing 6 in a 12-month period. The other patient has filled 4 controllers and 2 relievers, and that particular AMR would be 0.67, and they would be compliant with this measure. So with that, you can still see there's some area of opportunity, even if the AMR is perfect or is greater than 0.5, there's still some areas of opportunity to get a patient to maybe consider filling that controller every day, making sure they're using it not only when they're having symptoms, but when they're also feeling normal. This is really FYI. These are the list of controller medications that make up that definition of controller. I think it may be surprising, but there's other medications than just inhalers in the controller space. There's biologics, there's leukotriene modifiers. So the controller adherence can really change a lot if they're on multiple different controllers. So keep that in mind. The reliever medications are the short-acting beta-2 agonists like albuterol and levoalbuterol. I put a little note here that ampules for nebulizers are not included. But what I didn't measure and what I forgot to measure is that this is being focused on patients 5 to 18. All right, so a little more detail here. AMR is a quality measure defined by the National Committee for Quality Assurance, or NCQA, which gives us guidelines through the Healthcare Effectiveness Data and Information Set, HEDIS. All right, all that to say that it needs to be standard and measurable through administrative claims so that performance can be benchmarked across health plans nationally. So it is some limitations with that when you're trying to normalize everything to claims data. But and so the persistent definition definitely isn't going to match one how you clinically define persistent, like we did earlier in this talk. But persistent in terms of claims is members with at least one of the following criteria: 1 ED visit or acute inpatient encounter, 4 outpatient or telehealth visits, and 2 or more asthma medication dispensing events, or 4 or more medication dispensing events. So even though it doesn't necessarily meet our clinical definition of persistent, I think these patients definitely could be, by focusing on medication adherence, these patients could definitely improve some of their outcomes. The studies for AMR that I think were really the benchmark studies for this have been around for about 10 years. But I did just want to highlight some of the outcomes of these studies. So to really provide the evidence for AMR's usefulness as a pediatric pop health measure. So the first study was a small group of commercially insured patients, 5 to 17 years old. And the main outcomes for this persistent asthma patient group was that patients with an AMR of less than 0.5 have a higher risk of exacerbation. So that's where that threshold really comes from in the next study as well. Also, maybe not surprising, but patients that were persistent and didn't have any controllers at all during a 12-month period were much more likely to have a risk of exacerbation than their members that had at least one controller. So that really pins the importance of stepping up for those patients that are poorly controlled to get them on a controller if needed. The other study was much larger, almost 20,000 pediatric Medicaid patients aged 2 to 18. But similar results where patients with an AMR of less than 0.5 were 60% more likely to have an asthma-related ED visit. So taken together, I think there's some evidence that AMR can be certainly a valuable measure, and one that, if focused on, could improve outcomes by reducing ED visits and reducing exacerbations for this population. So one of the last slides here is just to review some strategies to improve AMR. And I think I've really reviewed a lot of these throughout the presentation today. And I don't think, surprisingly, I've included resolve medication access barriers at the top, because I think that's the first step to getting patients their medications they need to improve their adherence with controller inhalers, and also get them the medications that are guideline-based. Reviewing the asthma action plan, I think, is a crucial piece of this equation, giving those patients the understanding of when to use their inhalers and how to recognize symptoms that would require a reliever inhaler, and reinforcing using the controller inhaler every day. I think a teach-back approach is really helpful with this, to really make sure the patient understands these concepts, because I think patient understanding of inhaler technique and also inhaler use is one of the most challenging things for patients and families when they go home and the dust is settled. Pretty self-explanatory, reviewing asthma control and following guidelines to step up or step down therapy. And we reviewed the asthma pathway that can help you, if needed, to make those decisions. In line with stepping up therapy, single maintenance and reliever therapy is an interesting concept in asthma medication ratio. So if you're using SMART, you're using a defined medication like budesonide formoterol, which is defined as a controller. So they're not going to really have those reliever medications in that 12-month time period if you're using this medication daily and as needed. So I always like a good incentive to drive a guideline-based approach that can be a little challenging. And so using SMART would definitely improve AMR, but more importantly, I think it's going to improve asthma outcomes for your patients that are uncontrolled and meet the qualifications. And the last thing I really haven't touched too much on today is patient education. So there's so many wonderful tools out there to educate your patients on inhaler technique, educate them on the importance of using inhalers. And I just wanted to mention 2 more free resources that are patient education tools that you have free availability to. The first is Mediglyphs. These are inhaler education handouts. They're developed by Nationwide Children's Hospital pharmacists, and they really go step by step through a number of inhalers. And they have spacers with masks, they have dry powdered inhalers, And it's a great tool to be able to walk through your patient while in the office, how to use the medication, and then send that home with them. So if they have any questions, they can see this nice step-by-step process that includes pictures for how to use the technique appropriately. I'm pretty sure if you search Mediglyphs in your search bar, it will be the only website that is relevant for asthma patients. So check that website out. We didn't for a long time have these externally available, so I'm excited that they're available to our entire asthma community. The other one is a newer resource. It's a very truncated, short patient video. It's 2 minutes long. It goes over the basics of asthma, what's happening inside their lungs, and how medications can relieve those symptoms that are improve lung function that are leading to those poor symptoms. Definitely reinforces inhalers, controller versus reliever, and it talks about using the inhaler correctly as well. I do want to shout out to our respiratory therapist team led by Susan Mills, who was our Partners for Kids asthma coordinator. And we also had Gloria Ayers from Nationwide Children's Hospital and Belinda Huff from Dayton Children's Hospital, all providing insight into how to make this content valuable for our pediatric patients. So we're working with some practices to get this into their after visit summaries and also into their offices and into their exam rooms so patients can watch it when they're waiting. So here's a list of the asthma resources we reviewed today. I do really hope these resources help guide decisions that can help lead to improved medication access and ultimately better asthma control for your patient population. If you use them and have suggestions, please don't hesitate to email me. We update all of our resources regularly and are definitely interested in your feedback. A lot of the ways we make improvement and we make new tools is when I hear consistent feedback from providers that they're having certain challenges. And with that, here is my email, and I look forward to hearing from you. If you haven't today, but also if you have additional questions after this, please don't hesitate to reach out via email. So thank you all. And should I open it up? Is there any questions in the chat, Brooke?
Not in the chat yet.
Okay. Would you like me to ask for questions now, or would you like to go through a couple of your slides?
I would like people to ask questions if they have them, either in the chat or they can unmute and ask you via voice.
All right.
We don't have any. Dr. Marco, thank you. That was excellent. Please go ahead.
Hi, Helen. I have a question. I see a lot of kids in school, and a lot of their symptoms sometimes are from anxiety, but they think they need the inhaler, so that's not gonna really give you the right information that you're gonna need for your AMR. So I try to educate the parents when I catch it, but sometimes just for them to take a deep breath is all they need because of their anxiety issues. So how do you separate those two?
Yeah, I think that's a really good point and something that I certainly haven't dealt with a ton in terms of inhalers used in that approach or having that education with the family. But what I'd say from an AMR perspective, there does have to be those clear claims events that put them as a persistent asthma patient. So if they've not filled more than 4 inhalers, if they don't have a diagnosis of asthma, they wouldn't fall into that persistent asthma denominator. So it does, and there's also a exclusion list of indications that would exclude patients maybe with like other breathing issues like cystic fibrosis. This probably wouldn't count as an exclusion, but I could also take a look at something like that and see if we are maybe hitting on some of those patients and communicate that up to NCQA and things like that to see if it's something that could be triggering those patients to fall into the AMR bucket, and they really shouldn't be. Does that answer your question? Thank you.
I did have a question. It's kind of it's very minor. When you say you had your unified preferred drug list, it says central region,
Mhm.
Medicaid. Does that matter, central region? Because I'm in Northeast Ohio and I'm not sure.
It's a terrific question, and I should have called that out more clearly because I use central region tabs for everything. But it really relates to what region they're branded with. So the central region is branded with Nationwide Children's, and the West region is the only other option, is branded with Dayton Children's logos. The content is usually 100% the same. There may be different tools that Dayton Children's has that we might use in some of those things, but from a unified preferred drug list perspective, it doesn't matter where you are in Ohio. We are pulling that from the state unified preferred drug list, so it would cover any region. Really great question, though. Thank you for that.
Thank you.
I have a question about the AMR, and if you are on Singulair and fluticasone inhaler, you sort of like get double credits. Like you could have like a pretty high rate of albuterol use, but you would still be able to like maintain your ratio. Is that what I'm understanding?
You are understanding that correctly. So some of the limitations of, I think AMR is great. That was very insightful because I went over that slide pretty quickly. So that is an opportunity for increasing AMR, but that's why when I show a practice their AMR and the data behind it, I want them to see the medications that make it up. So they recognize that they might not be adherent to their controller inhaler. They're just AMRs kind of a little bit inflated because they're using their Singulair regularly. So that's just, you nailed that. You nailed one of the limitations of AMR. But I think by looking at that list of medications, if you have that opportunity, that will give you a little more insight on some interventions, regardless if they meet the criteria of being greater than 0.5. That's a great point.
And sort of along the same line, like having people do automatic refills and like having pharmacies send them to families. Like, what is your thoughts on using that? Because again, it sort of raises your AMR by you really, as a child, really using those inhalers.
Another terrific question. It's one we've started talking about a lot in our initial work groups. I haven't decided the best way to approach this, but I know, it's much harder to influence the community pharmacies that are doing automatic refills as an opt-in for their patients. One thing as a practice that has been fairly successful in this space, but it is using only one refill when you prescribe albuterol. So the patient can fill one, they could get one more, but then you're going to get a refill request. And at that time, by reviewing that refill request and asking the patient, are you using this a lot, or is this something the pharmacy sent over? If they're using it a lot, it's a great opportunity to get that patient into the office. If they're not, then you don't need to go ahead and refill that medication. You can communicate with the patient to let us know when you're starting to run low, when that dose counter is getting a little lower. That's probably the quickest route to improving things, where patients just keep auto refilling things. That's the only real way I can think of right now for you as practice to control that. I'm still brainstorming and thinking about things from a pharmacy perspective. Really wish there was a way that as needed medications couldn't have auto refill option, but I think that might be a bigger task for another day.
Yeah, I have a follow-up question. Is there a way to tell if it's an automated refill request? Because I'm often getting refill requests, and I'd love to be able to sort out, is the patient asking for it, or is it just an automated pharmacy? And I don't know how to do that. Maybe there's something on Epic that tells you that, or I didn't know if you knew, Kellen.
It's another great question. I don't think I was at Westside Primary Care at Nationwide Children's as a pharmacist there for a little while, and I couldn't tell. I would always have to have a call with the patient to ask that question. You could contact the pharmacy, but I think the conversation with the patient would be more valuable. But your point's well taken. Like, it would be nice if you could assess that, and then you would know that the patient isn't asking for it yet. I don't know. I've not seen an ability to do that as it's currently relayed to your office via fax. we just had a process for assessing it each time they came through the long way. Really, really great questions. If there's anything else that comes up, please, like I said, please use this email. I learned from you guys. I learned from the community, people in the community that are dealing with these challenges, and it's really valuable for me to have this experience talking with you here. But hopefully we can continue this relationship now that you have my contact and can reach out to with any questions in this space. Not only for asthma, you have Medicaid coverage issues in general. I'd be happy to take a look at some frequent barriers.
Well, thanks, Kellen. I've seen your talk twice and I keep learning from it. So yeah, you're definitely, we appreciate your input.
Thank you so much. I appreciate that.
That was Dr. Hardy, not Brooke Powell. Thank you all for asking good questions. There's positive feedback in the chat as well. Last call for questions. Okay, hearing none, seeing none, we can do the wrap up, Kellen. Thank you. Regarding the CME and MOC2 evaluation and credits, I will be sending you the information via email, or a representative of Ohio AAP will. You will receive your certificate of completion within 10 days. If you have any questions about this presentation that I can liaise to Kellen, or about the CME and MOC, I can be your contact. We've been going back and forth with the registrations. Clearly, you all have logged in as me, so I'll have to figure that out. But you have my email going forward if you have any questions. And one more slide. So this, again, is the first series of 3 for the asthma training series first session. So session number 2 is going to be May 13th at noon. We'll go over school provider linkage and school-based asthma therapy with Dr. Allen. And then session number 3 will be June 10th at 12:30. We'll be hearing from Dr. Beck around asthma, health equity, and justice. There's a QR code there for more information. And around one more note about CME, this presentation will be available for watching on demand, and for you to request CME and MOC credit via that way. So more information will be coming to you on that. And again, I am your contact for any questions that you have. Okay, thank you everybody for your time today. Kellen, thank you so much for joining us today and for educating us. Look forward to talking to all of you soon, and thank you so much.
Thank you, guys.